one of the characteristics of or manifestations that could be aggression. The partial fetal alcohol kids actually had higher rates than the full syndrome or than those that did not have any fetal alcohol symptoms at all. And again, this is hard to explain. It's kind of counterintuitive. I don't think I saw a good explanation for this, but you can see here that for the partial, it's double than it is in the other groups. As far as Fragile X, over 40%, a little over 40% with aggression, compared to the normative population of only 5%. For Prader-Willi, 41%, again, very high number, with definite, and then almost a third with some aggressive violent features. And then tuberous sclerosis complex, again, very similar numbers, with both attacking others and attacking themselves, so self-directed aggression. And then winding up here with the Smith-Magenis syndrome, very high rates of aggression, 70%, and 50% destructiveness. And then finally, Creedy-Schott, both outwardly directed aggression with hitting and inwardly directed or self-directed aggression with hair pulling. Again, very high rates, 65% for both of those. Okay, so that's the background. Again, thinking broad-based that aggression is a symptom, and there are many possible explanations from a psychopathology point of view as to the etiology of the aggression. So let's talk about treatment now. First with ADHD, and again, Dr. Bussinger already talked a little bit about this. The first choice of medication really is to treat the ADHD. That there's a good chance that we can make it better, the aggression better, by treating the underlying. And I think of aggressive acting out as being emotional impulsivity, so if we can control the impulsivity, there's a good chance that they can get better. So Connor's group did a meta-analysis of the 28 studies that were looking at aggression-related behaviors in ADHD, and they found that the stimulants had a really good effect size of 0.84. And that was for actually overt aggression. They also looked at the 7 studies that identified ADHD as the primary diagnosis without comorbidity of another disruptive behavior. And the effect size dropped a little bit, but it's still a decent 0.745. So as was alluded to earlier, that if we can really target the ADHD and do a good job treating it, there's a real good chance that we can reduce the aggressive behavior. As far as looking at just atomoxetine itself, it wasn't really a direct effect on aggression, but it was more an indirect effect by looking at the ODD behaviors. So a lot of that anger in relationship to having limits set on them and that sort of thing. So because we know that ODD is a risk factor for aggression by itself and that there's a lot of overlap between ODD and ADHD, that we should consider the use of atomoxetine, especially given we talked about the tiers already, if they're refractory to the stimulants, if they're intolerant for some reason to the stimulants, or especially if they get worse with the stimulants. And one of the things that they also found, and this is that group with Jeff Newcorn and Biederman and all those folks, that we have to go high. We have to, we talked about in there about what's the off-label maximum, and that's the number that we're looking at if we're thinking about control of aggression in ADHD, if we're going to use atomoxetine, that it may have to be the much higher dose rather than the more typical dose. Okay, we all know that we can have the response that we don't want, that the kids can actually get worse when we're treating the ADHD. And so monitoring, and that's why I'm glad that we're starting at the very beginning by good evaluation and then careful monitoring along the way, because if we start to see that, we really should think about backing off these medications. All right, as far as ODD, even without ADHD, that thinking about using stimulants and atomoxetine as well.
Non-ADHD, ODD?
Now, I guess I should have prefaced all of this by saying that, you know, certainly for the disruptive behavior disorders, the first step is going to be some kind of behavioral intervention.
But even with that, so I mean, with
right,
caveats.
Right. All right. For conduct disorder, again, we know we throw everything at it, and pretty much hardly anything works, except that, as you mentioned, you know, that lithium has been, and these were hospitalized kids, so kids were really severely impaired, very aggressive, and it was statistically better than placebo in reducing the aggression. And this This is Malone's group. Another study, and this is more recent, 2009, that adolescents were treated with lithium with or without an atypical, and that they showed reduction in aggression, that the lithium plus the atypical was actually a better response, 2 to 1. So we can talk about that one too. And in monotherapy, you can see it goes all the way from open label studies all the way up to randomized double-blind studies. And they looked at all the typical ones that we use. And with the exception of quetiapine, that they all significantly reduce aggressive behaviors when compared to placebo, but not compared to each other. So yeah, the quetiapine results were pretty disappointing. All right, you mentioned Depakote, divalproex. Monotherapy. In fact, they were so severely violent that 2/3 of them have actually been incarcerated for their violent behavior. And they looked at this, I commented this on Thursday, that they're looking at quote-unquote low dose, less than 250, that's like homeopathic dose. And then what they call high dose, 500 to 1500, is really kind of regular dosing. No difference in change in anger scores, but the high dose did show better impulse control, and by extension, thinking that that would be better for aggression. So I don't know whether they have redone this study with more clinically based dosing, open dosing, where I don't know if they've done that or not. I didn't see it. All right, real quickly, mood disorders. Usually start with the SSRIs. It's felt that if we decrease their negative affect, possibly impulsivity, that they will get less aggressive. As far as bipolar disorder, pretty much the medicines that have been used traditionally along the way for treating aggression are the medicines that we use anyway for treating bipolar disorder. And basically you want to follow the treatment guidelines. All right, severe mood dysregulation. I'm going to comment on 3 studies here that looked at meds. The first one was a 6-week RCT using lithium in children and adolescents. We have another one that ADHD patients that had comorbidity with either bipolar disorder or mood NOS. And that mood NOS is an umbrella under which severe mood dysregulation was included. And they used various different kinds of meds, but mostly they used aripiprazole. And then the third one is early young children and pre-adolescents, ADHD and severe mood dysregulation, and then used methylphenidate and behavior mod. And of those 3 studies, only this one right here showed any significant treatment effects. And so the authors of this study, Waxmansky and those folks, said, quote, the use of mood-stabilizing medications as a first line may not be necessary to achieve improvement in kids with ADHD and SMD. They couldn't comment because they didn't really look at that issue about just SMD without ADHD. So we'll have to kind of figure this one out as we go along. Okay, anxiety, not a lot of studies for med use in PTSD. You know, we don't have any approved meds for PTSD in the pediatric population, so we extrapolate from the adult studies. Again, start with the SSRIs would be reasonable. These 2 particular medications are approved for use in adults, although I have my reservations about using paroxetine. Start low and watch for exacerbation of irritability. And if they're partially effective or ineffective, they can be augmented with various different kinds of things. And again, sort of extrapolated from the adult literature. As far as panic is concerned, again, nothing's approved for kids in this age group. For those that are used in adults, we can use them off-label. And again, watching to make sure that they don't get worse as we're trying to get them better. We'd really like to avoid the use of benzodiazepines. Not only can they become disinhibited, but they can also like them too much, especially the adolescents. So I'll leave that as that comment. And then, of course, psychosis. Looking specifically at aggression in early onset schizophrenia, there's very little data out there. Again, we're extrapolating from the adult studies. They looked at